I think we are live now. Good evening, everyone. Welcome to this session. Welcome to this Super 30 session on behalf of Arise Medical Academy for FMG students. The exam is just around the corner. So just waiting for a few more of you to join in, and then we can start with the session. Hello, medic school nerds. Hello, 𝗵𝗵𝗃𝗃. Good evening. I hope all of you are doing great. Good evening, Khan Brotherhood. Good evening, Ashish. Good evening, everyone. I will keep saying, and you will keep asking, Sir, kya PDF milega? The PDF of this session will be available through the link shared in the comments box as well as in the description of this video. So after the class is over, after the video is over, you can go after some time, obviously, you can go and download from the link given in the description. So yes, you will get PDF, but at the same time, please listen to the session. I have about 1 hour, 20 minutes at my disposal, and I will be discussing 30 important questions. That is why it's Super 30 in pediatrics. These 30 questions, I will discuss 30 topics also along with key one-liners for your exams. I hope you're going to benefit from it. Right, so good evening, everyone. Just waiting for a few more of you to join. And in the next 2 minutes, I will be starting the class. So I hope your preparation is going fine. I hope also that all the notice-related controversy, the outcome was good. And in the coming days, it is going. Once the official notice comes out, it is going to settle down. So all of you who are going to sit in the exam, my earnest advice to you is please focus on the exam. Internship hoga, nahi hoga, notice when it will come. What about compensation certificate? All this can wait. For now, just focus your energy, your entire focus on cracking the exam, right? So let us start with the session. Medic school nerds, in case they don't mention anything, you should mention according to worldwide causes. That is a general way we teach. That is the way it has been described, not only for FMG, but also for NEET PG and INI-CET in future. Remember that if specifically India they ask and there is a separate list, you answer according to India. But if they say world, overall world will be the same causes that you will be mentioning, right? For example, if they say what is the most common cause of neonatal sepsis? In the Western world, it is group B streptococcus. And if they don't mention anything, your answer will be group B streptococcus. However, if they specifically mention India, the answer will be Acinetobacter followed by Klebsiella. It is an update which I've already shared with a lot of you in our subsequent discussions, right? So let me now start with the session. In between, whatever doubts are there, I will keep on taking, but will not compromise on the session. For those of you, most of you know me already who are attending the session. For those who don't know me, I'm Dr. Sandeep Sharma. I'm pediatric faculty at Doc Tutorials. And in the offline segment, I'm associated with Arise Medical Academy. And I'm going to discuss 30 important questions and topics. These are standard questions. A few of them are from FMG exams. A few of them are modified repeats. A few are modified questions from NEET PG. A few are fresh questions, which try to portray an important concept for you. So with you can follow me. You can ask whatever doubts you have after the session in the comments. I will be trying to answer that. You can also message me personally on Instagram. This is the mail. This is the Instagram link. You can also scan it. It will be available to you. So without wasting any time, let us start with the question. Question number 1. Which among the following should be performed as the next step if a neonate undergoing resuscitation has a heart rate less than 60 per minute despite adequate PPV? Despite adequate PPV. So what is your answer? I'm just waiting for you to tell the answer. Have a look at it. And RJ Medico, time is limited. Medicine session, endocrinology, hematology, I will be taking this weekend itself, right? But let us focus only on pediatrics because that is what we are discussing here. So YouTube session, question number 1, have a look at the question, read carefully, and then give me the answer. And then we discuss all the key points here. Which among the following should be performed as the next step if a neonate undergoing resuscitation has heart rate less than 60 per minute despite adequate PPV? Remember, neonate resuscitation, the sequence is always initial steps, including temperature management, then suction the airway, breathing ensured by positive pressure ventilation. And if PPV alone is not effective, you intubate and give chest compression. That is also not effective. Then you go for drugs in the patient, right? So question number 1, the answer to this question is, most of you have answered it correctly. All of you have answered it correctly, except a few. The answer to this question is C, intubation and chest compression. This is a modified question Modified repeat from NEET PG entrance exam. Why am I discussing NEET PG? Because we are discussing a topic and it is always better to take an actual MCQ and discuss the one-liners related to it. So answer to question number 1 is C, intubation and chest compression. आप सीधा भी आंसर तक पहुंच सकते हो. There is another way that you can rule out the options and reach the correct answer. Look at the other options. If adequate PPV, what is adequate PPV? If positive pressure ventilation has been given for 30 seconds, that is considered to be adequate PPV. So if someone asks you, what is adequate PPV? Positive pressure ventilation, that is bag and mask ventilation given for 30 seconds at least, is called as adequate PPV. So if you have given for 30 seconds, patient not improving, obviously you have to go to the next step. Continuing PPV for 60 seconds is not going to be the answer. Option number B, give epinephrine is not going to be the answer. Why? Because till you give chest compression, there is no role of giving epinephrine in the patient. Giving 100% oxygen is also not the answer here, because the problem here is newborn is not breathing and he's developing severe bradycardia because of hypoxia. Because the respiratory effort is not there, so giving 100% oxygen is not going to be effective. You can reach the correct answer either by ruling out the option, or you can straight away go to the correct answer and mark it. Question number 1, answer is C, right? Look at the neonatal resuscitation guideline. I will do a quick summary and then we will discuss a few one-liners which can be asked to you in the exam. Whenever a newborn comes to you and before the newborn is born, what do the guidelines say? First of all, there is antenatal counseling, team briefing and equipment check which needs to be done before birth happens. Antenatal counseling means you look at the risk factors of the mother. Team briefing means one should be a leader, one should be assistant, and one nursing staff or paramedical staff should be there to hand over the equipments and for making and putting the catheter. And third will be equipment check, which is very important in a country like India. All the resuscitation equipment should be in working order. After that, you wait for delivery to happen. As soon as birth happens, you ask 3 questions to yourself. Is it term gestation? Is there good muscle tone? Did the child breathe or cry at birth? Everything good, you will give routine care to the child. Routine care means only look at the general vitals of the child, give 1 dose of vitamin K, and after showing the gender of the baby and doing the formalities, hand over the baby to the family. Routine care, no resuscitation needed. If answer to any of them is no, we perform initial steps. A child who's either preterm or there is poor muscle tone or did not cry or breathe at birth, what is the first step that you will do? Initial steps need to be done. In initial step, you will put the child in the radiant warmer, warmth is provided. Then you will dry the child. Then you will make the child stimulate by either rubbing the back or trickling the sole. Then you will straighten the neck, position airway. You can put a shoulder roll. You can roll a towel and put under the shoulders of the child. It is a practical thing. And suction. Suctioning means cleaning the airway. Which should be suctioned first? Always remember, mouth is suctioned first and nose is suctioned later. This is a past MCQ as well, right? So mouth is suctioned first, nose is suctioned later. There is no role of esophageal suctioning and there is no role of tracheal suctioning in any newborn. So remember, if there is an option which is saying esophageal or tracheal suctioning, that will never be the answer. Initial steps should be done as soon as possible. And after that, you will check for poor respiratory effort, apnea or gasping, and bradycardia. What is bradycardia newborn? Heart rate less than 100. If any of them is present, you start with positive pressure ventilation. You take a ambu bag, attach a mask to it, cover nose and mouth, and push air into the airway of the child. Positive pressure ventilation is given initially via bag and mask ventilation. So it is also written as bag and mask ventilation. And your assistant will attach pulse oximeter to the child to check for SpO2. Where do you attach pulse oximeter? Right hand should be preferred for that. This is something I have already discussed multiple times in the class. Many of you might be listening to it for the first time here. I am going very fast because this is a topic I am quite sure most of you have done it already. So I'm just quickly going through so that your memory gets refreshed and we can focus on some scenarios in this topic. So attach pulse oximeter in the right hand and give PPV. When you give PPV or bag and mask ventilation, it should be initially given for 30 seconds. And then after 30 seconds, check for heart rate. If the heart rate is still less than 100, take steps to ensure adequate ventilation. You will consider intubation, but it is not mandatory. If the heart rate is less than 60, despite PPV, this is what the question was saying, you will intubate, give positive pressure ventilation via endotracheal tube, Chest compression should be started by your assistant. 100% oxygen is mandatory at this step, and coordination should be done. The coordination ratio is 3:1. What is 3:1? 3 compression followed by 1 breath should be given to the child. And the nursing staff will put a umbilical venous catheter here to obtain IV access. PPV and endotracheal. Remember that when you are giving PPV plus chest compression, it should be done for 60 seconds before you go to the next step. So remember the funda. This was the MCQ asked in January 24 exam. If PPV alone is being done, you check for 30 seconds and then move to the next step. If PPV and chest compression both are being done, you wait for 60 seconds and then move to the next step. Remember this funda, 30 and 60. PPV alone, 30 seconds, PPV plus chest compression, 60 seconds. If you remember it, your 2 past MCQs will be correct, right? Adult का बात नहीं कर रहे हैं तो adult की बात नहीं करेंगे. When we discuss adult, then we will discuss about adult. This is newborn. Newborn 3:1 ratio of compression to ventilation is asked. In case of children and adults, it comes down to single rescuer, double rescuer. Those are CPR guidelines, which have nothing to do with the neonatal resuscitation guidelines. Please do not mix them. Neonatal resuscitation is for a newborn who's born and not crying or breathing at birth. That is neonatal resuscitation guidelines. And after PPV and chest compression for 60 seconds, patient is not improving, give heart rate is still less than 60, give epinephrine, also called as adrenaline. First epinephrine should be given after 60 seconds gap, and subsequent doses can be given at a gap of 3 to 5 minutes each, right? And rule out other causes like pneumothorax and hypovolemia. And after every dose of epinephrine, go back and continue with resuscitation. Now, what are the key points you need to remember for the future exams? Remember that the principles, now I'm writing some very important points here. Principles of resuscitation, principles of NRP. They say the sequence to be followed. The sequence to be followed in the patient should always be TABC. What is TABC? First, ensure temperature of the child. Then you'll clean the airway. Then you go for breathing efforts. And C stands for circulatory efforts. So temperature and airway cleaning will be a part of the initial steps. Breathing can be ensured by ensuring positive pressure ventilation, either via mask or later on, if heart rate is below 60, through the endotracheal tube. And circulation can be ensured by chest compression. If that is not working, you will go for drugs like epinephrine in the patient. So sequence is TABC, very, very important. It is a potential MCQ for your exam. What is the sequence to be followed in neonatal resuscitation? Guideline तो पढ़ लिया, but वहाँ पर 4 option हो सकते हैं. You can get confused. ABCD, ABCT, CABT, and so on. Your correct answer will be TABC. Temperature and airway are initial steps. Breathing is ensured by positive pressure ventilation. Circulation is ensured by chest compression, followed by epinephrine. You cannot jump these steps. So remember, I'm putting a star. It is a very, very important thing. Add it to your notes. And if you have already know it, revise it for your exams. What are the other things you need to know? Second thing for your exams that you need to know is that whenever you do resuscitation, there should be initial steps which should be done. After that, you should be going for bag and mask ventilation. Bag and mask ventilation is positive pressure ventilation, which should be done for 30 seconds. After that, if heart rate is less than 60, then you will go for intubation and give PPV via endotracheal tube, plus start giving chest compressions to the patient. And this should be done for 60 seconds. And if the heart rate is still below 60, then you will give epinephrine to the patient. And after giving epinephrine, you should come back to this step. So cycles of this will continue. This is the summary that you need to remember close to the exam, so that if they ask you what next needs to be done, you don't go wrong in the exam. Another scenario, if the examiner says, neonate, I'm discussing some scenarios here. These are, some of them will be in addition to what we have discussed, because we don't want to miss out on any potential area from where MCQs can leak out. So if the question says there is a newborn having hypovolemia, neonate is having hypovolemia. Hypovolemia means decreased circulatory volume. Decreased circulatory volume, which is nothing but shock in the patient. So in case a newborn is in shock, he will not respond to all the measures that we have taken. How you are going to manage this patient? So any hypovolemia, any shock patient, you will give normal saline. You will give normal saline, IV bolus, 10 ml per kg. Normal saline, IV bolus. Normal saline means 0.9% saline will be given. IV bolus, 10 ml per kg. And if bleeding is present, you will arrange for blood transfusion in the patient. You will arrange for cross-matched blood transfusion in the patient. What kind of blood should be given? Whole blood should be avoided in newborns. Young children, we prefer PRBC. What is PRBC? Packed red blood cell transfusion. Packed RBC transfusion should be preferred in the patient. So this is a scenario, additional scenario you need to remember if you get asked in the exam. If the examiner says there is a neonate who has passed meconium in utero, there is a newborn who has passed meconium in utero, also called as meconium stained liquor, MSL. MSL stands for meconium stained liquor. Meconium stained liquor. If there is a newborn who has passed meconium in utero, what to do? As soon as birth happens, check if the newborn is having heart rate more than 100 per minute or not. Is there good respiratory effort? Is there good muscle tone? If all are yes, you will label the baby as vigorous baby. This is again a MCQ point. Not asked in FMG, but just a matter of time before they ask an exam. When you use the term vigorous baby, what do you mean? Vigorous baby term is used in a newborn who has passed meconium before birth. So in bachon mein, where as soon as the child is born, check for three things: heart rate more than 100, good respiratory effort, good muscle tone. Everything yes, vigorous baby. Vigorous baby is a healthy baby. Vigorous baby needs no resuscitation, only routine care is needed. So they can give you this scenario and ask you, what next needs to be done? Your answer will be no resuscitation needed, routine care is good enough. On the other hand, if the answer to any of them is no, you will label the baby as non-vigorous baby. Non-vigorous baby, and non-vigorous baby needs resuscitation. Some year back, हम क्या करते थे? In the older guidelines, some of the guidebooks still talk about older guideline. Ignore that. Earlier, what we used to do was we used to intubate the patient and then we used to do tracheal suctioning. Remember that tracheal suctioning is no longer routinely performed. In fact, nobody does it anymore in clinical practice, right? So resuscitation kaise karna hai? The usual way that you have discussed: perform initial steps as soon as possible and start with positive pressure ventilation, right? So the usual resuscitation guidelines will be applicable here also. But the initial categorization will be difficult. It will be different. You might get another MCQ in the exam. All of the following are used to define a vigorous baby except. Suppose question aaya. All of the following are used to define a vigorous baby except. And there will be four options: heart rate, respiratory effort, tone, color. What will be your answer? The answer will be color of the child. Color is not used to define a vigorous baby. Again, it's a past MCQ. So whether they put a scenario or they put one-liner kind of question on this, you should be able to mark based upon the information that we have just discussed. This video will be on YouTube, so you can listen to it again. You can do a quick revision in 1.5x or 2x speed just before the exam when you are revising pediatrics in the last week. And as I said before, PDF will be available in the link provided to you. For now, just focus on listening to me and try to understand. 80-90% if you're getting, you're doing absolutely great, because 10-15% some new things I will be adding just for the sake of because we need to plug the gap from where questions might be. Next thing, if you, in case, another thing from where question can be asked: which parameter you assess to check whether the resuscitation is going properly or not? So improvement in heart rate, remember, improvement in heart rate is the best indicator. Improvement in heart rate is the best indicator of adequacy of resuscitation as well as ventilation in the patient. It is the best indicator of adequacy of resuscitation as well as ventilation in the patient, right? Another one-liner. If resuscitation is being done, and heart rate becomes equal to or more than 100 per minute and respiratory effort appears, what next to do? Stop resuscitation. If heart rate at any step becomes 100 or above, your resuscitation is successful. So stop resuscitation and give post-resuscitation care. You give post-resuscitation care to the child. So stop resuscitation and give post-resuscitation care. Another one-liner can be asked. What is routine care in the child? Routine care. Routine care needs monitoring of the child, take vitals, take APGAR scores. You know that APGAR scores are taken at 1 minute and 5 minutes of life in every child, every normal child. So take APGAR scores and give 1 dose of vitamin K. You give 1 dose of vitamin K intramuscularly. Yahan par 2-3 points are important to revise. Why do we give dose of vitamin K at birth? It is given to prevent a disease known as hemorrhagic disease of newborn. It is given to prevent a disease known as hemorrhagic disease of newborn. Hemorrhagic disease of this is a 2021 past FMGE MCQ also, you can remember. Hemorrhagic disease of newborn is also known as VKDB. So don't get confused if they repeat the question and change the name of the condition. VKDB also stands for vitamin K dependent bleeding. Why do we need vitamin K? You need to understand. Every child, when he is born, the transplacental transfer of vitamin K is not very good in every way. And so the liver stores of vitamin K are very less. And vitamin K, you know that it is required for the formation of coagulation factors. So what will happen? So baby, if you don't give vitamin K at birth, there will be deficiency of clotting factors, and that can cause spontaneous bleeding in the child. That disease is called as hemorrhagic disease of newborn or vitamin K dependent bleeding. Why do we need to supplement it? Because we are recommending exclusive breast milk, and breast milk also is not a good source of vitamin K. And so Government of India has made it mandatory, whether it is a private practice or a government institution, 1 dose of vitamin K has to be given. If someone fails to give it, it's not only bad karma for you as a doctor, but also a medico-legal responsibility. You are on the wrong side of law. It has to be given. There was somebody who was asking me, sir, somebody was saying कि vitamin K private sarkari में देते हैं, private में नहीं देते. It is a rule. You have to give it. You have to give it. So 1 dose of vitamin K. So examiner can ask you what is the dose of vitamin K at birth that you have to give. All babies, the dose will be 1 milligram intramuscularly. You can give into the anterolateral thigh. And in case if it is an extremely low birth weight newborn, that is the birth weight of the newborn is, if the birth weight of the newborn is less than 1000 grams, in such patient, the dose will be 0.5 milligram intramuscular. Right? Otherwise, the dose will always be 1 milligram intramuscular. And which is the best form? The best type of vitamin K is vitamin K1. There is a K2 form, there is a K3 form. K1 is the best form that you will be given. So these are the routine care and the different scenarios. I have spent some time. Don't worry, I'm not going to take so much of time on one topic, but it is a tough topic and it is a frequently asked topic. So I try to discuss the maximum I can. Before we go, another table that you often tend to miss out, ET tube size for newborns. So they can put a case scenario and ask you what size of endotracheal tube you will use for intubation. So remember this table. If the baby is born and weight is less than 1 kg, or he's born less than 28 weeks of estimated gestational age, 28 weeks se kam hai. So which size of ET tube you will be using? 2.5 size tube. If it is 1 to 2 kg and 20 to 34 weeks, it will be 3 size ET tube. 2 to 3 kg, 34 to 38 weeks, 3.5 size hai. Ye size hai, numerical numbering hota hai. We look at the internal diameter. uske hisab se the size is mentioned. So 2.5, 3, 3.5, these tubes are available in the market. So you have to make sure that appropriate size tubes you are using for intubation. And 3 to 4 kg or more than 38 weeks, you will be using either 3.5 or 4 size. Generally, we go for 4.0 size, but sometimes if the baby's weight you find on the lesser side, then you can go for 3.5 as well. So it is a range, it is not a standard thing that is asked. So this is another thing that you need to add and cram it up. Have a look at this table again before you go to the exam. So this is newborn resuscitation. Going back to the question, what did we see? The question number 1. If a neonate is undergoing resuscitation, adequate PPV done, heart rate less than 60, what next needs to be done? Intubation and chest compression needs to be given intubation. That is the first thing to remember. Let us go to the question number 2. Question number 2. Sigmoid-shaped growth curve is shown by which among the following tissues or organs? Have a look and give me the answer. Sigmoid-shaped growth curve is given by which among the following tissues or organs? What is your answer? I'm waiting for the answers. There is a lag between what I say and what you type. So I'll just wait. Sigmoid-shaped growth curve, also called as S-shaped growth curve. S-shaped growth curve is typically seen whenever the patient is having somatic or skeletal growth curve. Somatic growth, that is the answer. That is the answer. Growth curves, let us revise them. We have discussed it, but you are marking it wrong. Many of you are marking it wrong. It will be suicidal in the exam. Growth curves have been asked 3 times in one way or the other in the FMGE exam. Every alternate year, they have been asking since 2021. So 3 times, since 2020. So 3 times it has been asked. The answer to this question is D, that is somatic growth, not gonadal growth. Sigmoid shape kya hota hai? Have a look here. These are the 4 types of growth curves. When the growth curves attains a plateau and becomes stable throughout lifetime, only growth happening between the first 2 to 3 years, that is called as the brain growth, also called as neural tissue growth. Then if there is rapid growth till first 3 to 4 years, then the growth becomes relatively stable and then again picks up during onset of puberty. This is called as sigmoid-shaped growth curve, also called as S-shaped growth curve. And this is typically shown by skeletal tissue, also called as somatic growth curve. Somatic growth curve, right? So ये होता है sigmoid shaped growth curve. What is sigmoid shape? S-shaped growth curve. Rapid growth in the first. मैं example हमेशा देता हूँ in my class. Mother comes to you, brings her 5-year-old child. She says, my child was growing rapidly till 4 years, but last 1 year his height is almost same. I am concerned my child is not well. You will counsel the mother that your child is likely to be good. Just check the malnutrition features are present or not. And then you will counsel the mother and say your child is following a normal growth curve. What is the normal growth curve? Every skeletal tissue in babies, in children, there is rapid growth first 4 years. 4 to 10 years, it remains stable. And then again picks up when puberty comes. We call it as pubertal growth spurt. So it produces a typical S-shaped growth. That is skeletal or somatic growth. Don't get it wrong in the future in the exam. Third type of growth curve is this, where a partial bell-like shape is getting produced. Hyperplastic tissue becomes between 4 to 8 years and then it regresses and becomes stable for life. This is lymphoid tissue. So if you get a photograph like this is lymphoid tissue growth curve. Photographic depiction has been asked to you in FMGE exam in the past. And fourth, no growth happening and then the growth rapidly develops after 12 years. What is this growth curve? This is gonadal growth curve. So gonads grow like this. So brain, skeletal, lymphoid, gonadal, don't get it wrong in the actual exam. You can get a photograph, you can get a one-liner, you can get a match the column. These are the important things. There is another MCQ which has been asked last year and again mentioned wrongly by many of you. There was a recent MCQ asked. Which of the following corresponds to gonadal growth? Which of the following corresponds to gonadal growth? And options given were brain, skeletal, also called as somatic, lymphoid, and cardiac. What is your answer? Which of the following corresponds to gonadal growth curve? This is a recent MCQ. What is the answer? Tell me. Give me the answer to this question. Which of the following corresponds to gonadal growth? Nidigonda Mulya is saying skeletal growth. Absolutely correct. Absolutely correct. The answer to this question is B, skeletal. What this question is saying is, which organ as a body may have, which is the organ in the body, when gonadal growth picks up, that growth, that tissue also picks up. So when puberty comes, there is a uptake in the growth of gonads. There is also an uptake called as growth spurt. So skeletal tissue is the answer here. Skeletal tissue is the answer here, and most of you have answered it correctly. Don't get it wrong in the actual exam. It's an actual MCQ, can be repeated in the paper. So question number 2, answer is done. Question number 3, look at the image below and tell the approximate age at which this milestone is normally attained in a child. What is this child doing? And what is the answer? See carefully and give me the answer. This is a development milestone which has been depicted in the photograph. So this is a child who is doing crawling upstairs. Crawling or creeping upstairs comes at 15 months of age. Walking upstairs with support comes at 18 months of age. Walking upstairs with support, 18 months of age. Walking up and downstairs, but 2 feet at each step, that comes at 2 years of age. And these are the frequently asked milestones related to stair walking. So this child, if he was holding a hand, holding a finger, and holding a rail and was going upstairs, the answer would have been 18 months. Remember, so crawling upstairs comes at 15 months, and that is the answer. Question number 3, answer is B. Development milestones, we have discussed already multiple times at multiple forums. Make sure that you read them, you revise them, and if you are running short on time, fine motor milestones as well as cognitive milestones are more frequently asked compared to gross motor and language milestone. Having said that, if you get a question from language milestone and padh ke nahi jaoge, so then don't blame me, because end of the day, every milestone is important. But generally what we see is that fine motor and cognitive milestones, more questions are asked in the exam. Just a minute. More questions are asked in the exams. Am I audible and visible? Please confirm, all the students, so we can continue from where we left. Please confirm. Now, thankfully, in Chandigarh right now. So don't panic, yaar. These internet disruptions will happen at every stage. Whenever it sometimes happens in the exam center also. Those who have given the exam previously would know. So don't panic at that time. It is you will get sufficient time in the paper. So coming back to the question, I will start from where I had left. Question number 3. This was a child who was crawling upstairs, and because he's crawling upstairs, crawling or creeping upstairs comes at 15 months. So the last point I was making was, if you are running short on time, go through the PYQs of related to development milestones and focus on fine motor and cognitive, from where more frequently or tough questions are asked in the exam, right? Having said that, let's go to next question. Question number 4. There is a 3-year-old child with loose watery stools. He comes to you. You assess dehydration in the child. What shall be given to the child if he is irritable, eagerly drinking, and has delayed skin pinch? So look at the question, and then we will do quick revision of this question, quick revision of this topic, which is very frequently asked in the exam. So what is the answer? Read the question carefully and give me the answer. First of all, you have to assess the degree of dehydration in the patient. Irritable, eagerly drinking, that is increased thirst, and delayed skin pinch is pointing towards some dehydration in the patient. And some dehydration, you will be giving plan B. And what is plan B? WHO recommended ORS, also called as low osmolarity ORS, and that is the answer here. So answer to question number 4, the answer is A. Why not Risomal? Because Risomal is given in Kwashiorkor and marasmic child, severe acute malnutrition child who develops dehydration. Home-based fluids will be recommended in plan A, where diarrhea is happening, but there is no dehydration. Ringer lactate is a IV fluid, and this will be recommended in case a patient is having severe dehydration. And the question will say unable to drink. There the answer will be Ringer's lactate, right? So yes, the dose is absolutely right, 75 ml per kg, which is given over 4 hours. So let us do a quick revision of the topic. I am going to do it in a very different way. The same thing that you have discussed, but in a slightly different way so that you can revise in the exam. So a child comes to you with loose stools. A child comes to you with loose stools, right? Child comes to you with loose stools. First thing to do, assess degree of dehydration. Assess the degree of dehydration. What degree of dehydration you will check for? If the examiner is saying, I'm only writing a key point, this is a summary for your exams. This is a summary for your exams. If the examiner says child is alert, active, there is normal thirst, oral mucosa, that is mouth and tongue, they are wet, and there is a normal skin pinch test. You pinch the skin of the anterior abdominal wall, it goes back normally. The patient is likely to have no dehydration. In case you find that the examiner is saying irritable child, there is increased thirst, examiner will write eager to drink or eagerly drinking, and oral mucosa is dry, and skin pinch is delayed. You need to understand that skin pinch as well as the sunken eyes are not a very reliable criteria. And in these patients, you have to depend upon the thirst status. So skin pinch test will be delayed. In such a patient, the likely diagnosis of the degree of dehydration is going to be some dehydration. And if the examiner says child is lethargic or comatose, that is unconscious, the patient is unable to drink, other features may or may not be present, oral mucosa will be dry and skin pinch test will be delayed. the patient is likely to have severe dehydration. Severe dehydration. What is the color coding, IMNCI coding that you will be using? So IMNCI code in such patient, no dehydration, it will be green code. In some dehydration, yellow code. Those who have given the exam last year, this was a question asked in one of the previous year papers. And in severe dehydration, pink code. There is no such thing as red code. Red nahi hota, right? So green, yellow, pink. रेड नहीं होता है. रेड लेबल जो है या रेड कोड जो है, रेड लेबल जो है वो चाय होती है, चाय भी होती है, राइट? सो ग्रीन कोड, yellow code, pink code, also called as green label, yellow label, and pink label for degrees of dehydration. And what is the treatment that you will be giving in the patient? Here you give plan A, here you give plan B, here you give plan C. Plan A includes ORT, oral rehydration therapy. For example, home-based fluids will be needed in the patient. In case of plan B, you will be giving WHO recommended ORS 75 ml per kg given over 4 hours. And in plan C, you will be giving IV fluids. What is the best IV fluid which is given? Ringer lactate. If that is not available, you will go for normal saline. So first you will assess dehydration and give this. Plus, all children also need oral zinc therapy given for 14 days. Even if the diarrhea is for 3 days, once started, it has to be given for 2 weeks. The dose of zinc has been asked in NEET PG exam 2 times. The dose is 20 milligram per day. And in case the age of the patient is less than 6 months, the dose will be 10 milligrams per day. So this therapy, that is giving fluid and giving zinc, needs to be given in all patients. Additionally, in case the patient is having dysentery, when would the patient have dysentery? In bracket, you can write blood or mucus present in the loose stool. In such a patient, you will be giving antibiotics in the child. So antibiotics also need to be added. Also means zinc has to be given and fluids have to be given. And what is the drug of choice? Oral ciprofloxacin, that is fluoroquinolones, are the first line agents that are recommended in these children. And in case the question says persistent diarrhea is present, if question says persistent diarrhea is present, what is persistent diarrhea? Diarrhea lasting for 14 days or longer. In such patient, you will put the patient on low lactose diet. Remember that probiotics are not routinely recommended according to WHO and according to Indian guidelines. IMNCI does not recommend probiotics routinely in the patient, right? So it's a very small flowchart kind of a thing, but it is a useful summary which you can get in the exam, and there is a possibility some question may come your way in the paper. Now, you need to know something which I have already discussed. INI-CET. There was a question this time, the recent INI-CET which has happened just a few months back, 1 month back. The question was, which is the most accurate parameter to check for dehydration in the patient? And this is something I have already taught even FMGE students of mine, right? So what is the answer here? This was the question. This was a one-liner question asked in INI-CET this time. Many students, INI-CET students also got it wrong. I know you will get it right. Which is the most accurate parameter to assess degree of dehydration? What is your answer? What is your answer? Give me the answer and we move to the next question. I would be very happy if you give me the correct answer. Yes, 𝗲𝗲, absolutely right. Thirst, right? Because mental activity can vary. Oral mucosa can vary. Skin pinch test, again, it's not a very, it depends upon the skin turgor, which may or may not be good in the child. But thirst status will always give you the best indicator of the degree of dehydration in the patient. So Mohammed, Sandeep, Bura, Mukesh, Meena, Kruti, Vyas, you have all got it right. The answer is thirst. It is INI-CET. Don't worry, I'm not preparing you for INI-CET. Just saying, because similar topic. This year, January, FMGE, it has been asked. This year, INI-CET, 1 month back, it has been asked. Who knows? It may be asked again. So don't make silly mistakes if you get a question like this. Let us move further. Question number 5. All of the following can be used to define severe acute malnutrition except. All of the following can be used to define severe acute malnutrition except. Read carefully and give me the answer. Now we can pick up speed. Easy questions are coming. I had kept the longer discussion questions early on in the paper. What is the answer? Read carefully and give me the answer. Read carefully. It's a controversial question. That is why I'm saying. What is severe acute malnutrition? Severe wasting, MUAC is less, and symmetrical edema is present. Right? Try to think. For ideally, it should have been or height below -3 standard deviations. Then it would have been easy. But they have given weight for age, which is not a parameter, and height for age, which is also not a parameter. Remember that weight for age, if it is less, that can also indicate acute malnutrition, because weight for age can be low in both acute as well as chronic malnutrition. However, height for age will never be low in acute malnutrition. That will always indicate chronic malnutrition in the patient. And so because it is asking except, the best answer among the option is B. This is a question which was asked 5 years back in NEET PG exam, and it was very controversial. So the reason I'm mentioning it is, suppose you get a similar question in the paper, all 4 options, you can easily rule out 1 or 2 options. 2 options you will get stuck. Out of them, go for the most likely and logical answer, and that will always be the correct answer. Remember, if height for age is less, that always indicates chronic malnutrition. It indicates stunting in the patient. It can never be acute. For acute malnutrition, weight for height is best. But if that is not possible, weight for age can sometimes be used. It will not be very accurate, but if we don't have an option, it can sometimes be used because it can indicate acute as well as chronic malnutrition. And so the answer to this question is B. So remember, what is the criteria that we follow? If you find weight for age below -2 standard deviation, also called as below -2 Z-score, we say patient is having underweight child. Underweight simply indicates malnutrition. It can be acute, it can be chronic. If weight for height is below -2 standard deviation, we use the word wasting. That indicates acute malnutrition in the patient, right? If height for age is below -2 standard deviation, we use the word stunting, and stunting always indicates chronic malnutrition. In both wasting and stunting, if it is -2 to -3, that is called as moderate malnutrition. If it is below -3, we call it as severe malnutrition. This is something that we have already discussed multiple times in the class. It is there in your notes also, whatever source that you have read from, right? So the question topic is done. Let us move to the next question. A child was suspected to be having Kwashiorkor. Which of the following are considered specific hallmark features? And it is very similar to an actual old MCQ of FMGE exam. Let us see if you can get it right or not. I have just modified the options a bit. What is the answer to the question? I'm very happy to see that most of you, almost all of you, are getting the answer correct. Yes, edema and mental changes. Remember, Kwashiorkor is characterized by hallmark findings of PEMG. PEMG stands for psychiatric or psychomotor changes. So mental changes will be there. E stands for edema. M stands for muscle wasting. And G stands for growth retardation. Out of them, mental changes and edema are always present, and that is why the best answer to this is B. Other options are found sometimes, but they are not specific for Kwashiorkor. Presence of edema and mental changes are considered to be specific for Kwashiorkor in the patient. So question number 6, and remember that Kwashiorkor occurs due to severe protein deficiency. Don't get it wrong. Severe protein deficiency causes Kwashiorkor. Severe carbohydrate or caloric deficiency causes marasmus in the patient. This is something that I know, will not get it wrong in the paper. Question number 7. A child is suspected to have. Nidhi is asking option number D. Flaky pen dermatitis and flag sign. Yes, Nidhi, flaky pen dermatitis and flag sign are the hair and skin changes found in Kwashiorkor, but they are not specific for Kwashiorkor, and they may or may not be present. Sometimes flag sign can occur in normal children also. due to hereditary causes. Sometimes there are certain syndromes in which flag sign can be seen. So question number 7, a child suspected to be having celiac disease is to be evaluated. Which of the following will be the first line screening investigation you will advise in the child based upon the latest guidelines? Read carefully and give me the answer. Celiac disease, also called as gluten sensitive enteropathy, is being talked about. The other name is gluten sensitive enteropathy. Bro is unsafe in the patient. So barley, rye, oats, and wheat should be avoided. Other types of grains, including rice, maize, chia seeds, tapioca, they are all safe in the patient. So gluten-sensitive enteropathy, what is the screening method of choice? Screening method of choice. Yes, it is always TTG, IgA antibody along with total serum IgA, and A is the correct answer. Remember, if they ask you a celiac disease patient, first of all, we will do screening in the patient. The best screening test is total IgA in the serum along with IgA TTG. If that is not available, we go for total IgA along with IgA variety of EMA. EMA stands for endomycial antibody. Endomycial antibody. That is the second best test that you will do. If they say what is the investigation of choice, the investigation of choice will be upper GIT endoscopy and biopsy. What is the site from where endoscopy is done? The best site, according to the latest guidelines, is duodenal bulb. Always take biopsy from duodenal bulb. Earlier, it used to be jejunal area. Now, duodenal bulb is the best site, so can be asked to you in the exam. So take endoscopy and biopsy from the duodenal bulb. And what is the grading of Kwashiorkor known as? The grading is known as Marsh grading. So Marsh grading is the name of the grading. Details of Marsh grading are asked in INICET exam, not useful for NEET PG or even for your FMGE exam. So grading is done by Marsh grading. Can you get a question? You can get question, but atypical rare things should not be read close to the exam. You should be focusing more on the repeatedly asked things. And what is the increased risk in celiac disease patients? These patients are prone to get lymphomas of the intestine. So lymphomas of GIT are common with them. And what is the therapy available in celiac disease? The only therapy available is gluten-free diet. Lifelong gluten-free diet is recommended in such patients. So lifelong gluten-free diet is recommended in these patients. Let us move further. Go to the next question. Question number 8. 29-day-old boy is transferred to the hospital from a peripheral center. Read the question carefully. It looks to be tough. Similar questions will be time consuming for you. I hope all of you know that there are going to be time bound sessions this time. So you get a question like this, read fast. And as you are reading, translate in your native language in your mind. कि ये कहना क्या चाह रहा है? And you will find that majority of such lengthy questions are actually very simple. So 29-day-old boy transferred to the hospital from peripheral center. Patient was seen for persistent vomiting. And he's having projectile vomiting, persistent projectile vomiting. Small mass is palpable in the pyloric area. Visible peristalsis is there. IV fluids were given and surgery was planned. What is the likely diagnosis? First of all, tell me the diagnosis in the patient. What is the likely diagnosis? Yes, diagnosis is CHPS, also called as IHPS. Mohammed, it is not intersusception. Intersusception mein hoga bleeding per rectum. There is no bleeding per rectum here. Red current stool mention karega examiner. This is a 29-day-old boy. Intersusception occurs between 6 months to 6 years. This is a 29-day-old boy. So 2 weeks to 3 months child having non-bilious projectile vomiting with a mass palpable in the upper abdomen and visible peristalsis. Likely diagnosis is CHPS or IHPS. What are the risk factors? What are the risk factors? Which of the following is a recognized risk factor? Male gender is a risk factor, and that is the answer. That is the answer. Mohammed, it is not a bounce up from me, but it is a question I made specifically for this session. I had to think. I was traveling somewhere, and I thought, okay, let me put a atypical question also, make you think a bit. You may or may not get similar questions, but you need to be mentally prepared for questions like this, right? If you get questions like this in the exam, actual exam, pass percentage will fall. We don't want that, but that will fall. But if you get this question right, that means whatever is the pass percentage, you are ready for the exam. Go with full confidence that you have read everything. Go for easy, common things. Remember, if it is a 6 month to 6 year child, pain abdomen, vomiting, mass, and bleeding per rectum, think of intersusception. But if it is a child in the first 6 months of life, particularly after 2 weeks till about 3 to 4 months, and there is a non-bilious vomiting, mass in the abdomen, projectile vomiting, and it is a visible peristalsis, then you will think of 𝗔𝗔𝗃. Male gender is a risk factor. Edwards syndrome is a risk factor. Rotavirus is not a risk factor. Trisomy 21 not a risk factor. Systemic erythromycin is a risk factor. Topical is not a risk factor. Right? Blood group B and O are risk factors. Yes, absolutely right. So there is a list of risk factors which have been provided to you. You can read it from there. So remember, 𝗔𝗃, key points to remember. The clues in the question will be age 2 weeks to 3 months. It will be a male child, more common in males. There will be presence of other risk factors. They may or may not mention. Risk factors will be blood group B and O. There will be use of erythromycin, obviously systemic, not topical. And there will be Edwards syndrome, Apert syndrome, Zellweger syndrome. These patients will have non-bilious projectile vomiting. They will have olive-shaped, key points I am writing so that close to the exam you can have a look again and revise. Olive-shaped epigastric mass. There will be visible peristalsis. Visible peristalsis. If you do X-ray of the abdomen, you will find a single dilated proximal stomach that is called as single bubble appearance. But single bubble is not present in all patients and it is not sensitive. So investigation of choice will be ultrasound of the abdomen. Complication in the patient will be hypochloremic, hypokalemic, metabolic alkalosis. Hypochloremic, hypokalemic, metabolic alkalosis. Treatment in the patient will be first IV fluids and correction of alkalosis, and then go for surgery in the patient. Good evening, Chela. So you can join from here and listen to the remaining discussion later on. So Ramstead spiromeotomy, but it is never done before correcting alkalosis and IV fluid. And when you are using IV fluids, remember, never use ringer lactate in alkalosis. Ringer lactate is a alkaline fluid physiologically, so it should not be used. Lactate hota hai, but inside the body it becomes alkaline. So never use ringer lactate in such patients. You should always be using either a 0.45% saline or a dextrose-based solution can also sometimes be tried. But ringer lactate will never be the answer in 𝗔𝗃 patient. Yaad kar lo, right? It is a common mistake a lot of you make. Hello, Varun Sani. Join the session from where you have joined. So the answer to this question is C, male gender is the risk factor. Question number 9. Look at the image and tell the likely diagnosis in this child with fever and rash. What is the answer? Hello, Nagarajan, Nityanandan. I hope you are doing fine. Look at the question and give me the answer. So this is what you call as slapped cheek appearance. Slapped cheek appearance. And slapped cheek appearance is typically seen in erythema infectiosum, also called as fifth disease. Fifth disease. Causative agent is parvovirus B19 in the patient. Complications. There are 2 complications you need to remember. Pure red cell aplasia as well as transient aplastic crisis, also called as transient aplastic anemia. And these complications are more common. They are seen in chronic hemolytic conditions. For example, if a sickle cell anemia patient or a hereditary spherocytosis patient develops parvovirus, he will have a higher risk of complication. So it is seen in chronic hemolytic diseases like sickle cell anemia. Like sickle cell anemia. It can also be seen in hereditary spherocytosis of the patient. Right? So this is the typical example. I hope you remember the 6 important causes of fever with rash. I have discussed so many times. this should be very clear. If the question says fever with 3 C's, cough, coryza, conjunctivitis, Koplik spots in the mouth, non-itchy rash coming on face and behind ear, going to the trunk, likely diagnosis will be measles. If the question says measles-like rash, but lymphadenopathy and palatal lesions called Forsheimer spots are present, that is rubella. Itchy rash coming on trunk, going to the face, polymorphous vesicles present, varicella. Slapped cheek appearance, erythema infectiosum. If the question says lesions present on palm, soles, buttock, and oral cavity, hand, foot, mouth disease caused by 𝗏𝗃 followed by enterovirus 71. And if the question says non-itchy rash coming after fever goes away and associated with Nagayama spots which are present on the uvula, the likely diagnosis will be roseola infantum, HHV6 and HHV7 will be your answer. These 6 causes, you should not get them wrong. In case you have not read them, please go through them once in the last week before the exam, very frequently asked in the paper. So all of you, I am quite sure, know the things. I can have a look at the live chat and you are answering it very rightly. So great, let us move further. जो पढ़ा हुआ है उसको बार बार नहीं करेंगे. Question number 10, least common finding seen in tuberous sclerosis. Now we come into a tricky area, a topic from their questions. It's an overlap between pediatrics, medicine, and dermatology. Least common finding they are asking. We will come back to this question. Let us do a quick review of the topic known as tuberous sclerosis. So in case you have not read this topic properly, only the key points I'm summarizing here. Also written as TSC, tuberous sclerosis. It is a type of neurocutaneous syndrome. It is a type of neurocutaneous syndrome. What is the type of inheritance? It tends to show autosomal dominant inheritance. Autosomal dominant inheritance. I'm putting a Q, it's a past MCQ point. What are the genes involved? There are 2 types of genes which are involved. We have TSC1 gene and we have TSC2 gene. Any of the 2 gene involvement can produce tuberous sclerosis in the patient. TSC1 gene is located on chromosome 9q. So which chromosome they are present? It is present on chromosome 9q. And TSC2 is present on chromosome 16p, that is short arm of chromosome. 9q codes for a protein known as hamartin. I'm discussing the pathology part here as well. And 16p codes for a protein known as tuberin. Either TSC1 or TSC2 involvement leads to the development of tuberous sclerosis in the patient. What are the key features of tuberous sclerosis? Key features can be divided into 3 parts: CNS, skin, and others. So first of all, CNS involvement. CNS involvement, these patients are characterized by the occurrence of cortical tumors. They are nothing but a type of benign brain tumors occurring in the cortex. Potato jaise chote solid tumors tend to form in the brain. Secondly, they are characterized by subependymal giant cell astrocytomas. They are a type of astrocytomas which occur only in tuberous sclerosis. They do not occur elsewhere. They are also called as SEGA. Subependymal giant cell astrocytomas. Third, there can sometimes be subependymal nodules. Instead of big tumors, only subependymal nodules will be there. Fourthly, these patients will have white matter changes or white matter abnormalities. आपको पता है ना, there are 2 types of matter, gray matter and white matter. So white matter abnormalities can be seen. And fifth, these patients will have seizures. What are the types of seizure? Example, I hope you have read that West syndrome or infantile spasm can occur in some varieties of tuberous sclerosis. Infantile spasm, it can occur, right? And last but not the least, IQ. IQ can be normal or it can be low. It varies from person to person. It varies from family to family. These are the CNS features. Second, we have the skin involvement. Skin involvement occurs in the form of shagreen patch. Shagreen patch, which is a rough, raised, yellow-white crusty lesion found in the lumbosacral region. Second, you will find that the patient is having hypopigmented macules on the trunk. They are also called as ash leaf macules. Hypopigmented macules will be present on the body. And thirdly, skin will be having benign tumors arising from sebaceous gland called as adenoma sebaceum, which are confused with acne and tend to occur on the face. They tend to occur on the face. So yaad kar lo, there is also a case scenario asked in non-FMG exam. Like there was another exam in which it was asked. The question was, there is a 1-year-old child who's having a recurrent infantile spasm showing 𝗵𝗄𝗃𝗔𝗓. He also has hypopigmented skin lesions on the body and has delayed development. What is the likely diagnosis? The likely diagnosis in the patient was tuberous sclerosis because he has CNS feature and he also has skin lesions present in the patient. So if any CNS and skin lesion are present, they are considered to be clinically diagnostic of tuberous sclerosis. Obviously, genetic analysis will be needed in the patient. Skin के और भी features हैं, but because we are doing a quick summary before the exam, so I'm not going into the details. Dermatology, you tend to read a triad known as Vox triad. Vox triad has been removed from all the non-derma textbooks for the simple reason Vox triad is seen in only 30% patients. Right? तो याद कर सकते हो as a part of the list, but remember it is not diagnostic and it is not found in all the patients. And thirdly, other organ system involvement. Other organ system involvement will be in the form of cardiac rhabdomyomas, which are found to be present in 80% in individuals. And we have retinal mulberry tumors, which are found in more than 70% of these patients. Last but not the least, there can be pulmonary benign tumors as well. Pulmonary benign tumors. And remember that drug of choice for West syndrome, WS is West syndrome, in tuberous sclerosis is always 𝗲𝗃𝗏 followed by ACTH. Normally it is ACTH followed by 𝗲𝗃𝗏, but in such patient, the drug of choice will be 𝗲𝗃𝗏 followed by ACTH. So we have done a very quick summary, but I've tried to cover some important points here. Have a look at the question. Least common findings seen in tuberous sclerosis. White matter lesions are common. Subependymal nodules are common. Subependymal giant cell astrocytoma, which is a type of astrocytoma, are common. What is the odd one out? Ependymoma, and that is the answer. It is not the question per se, but it is the topic summary that is important that you need to remember for future for your exams. If you have read it, if you have listened to it, given it a reading once before the exam, you will be quite confident in ruling out the option and still reaching the correct answer. Let us go to the next thing. 2-year-old child is brought by parents with history of seizures and developmental delay. So seizure is happening, developmental delay is happening. He has multiple hypopigmented macules over the back. What is the most probable diagnosis? Read carefully and give me the answer. I have discussed it. I have put 2 questions in succession on this. What is the answer to this question? This is the same. This is the same. Many times a same topic can be repeated 2 times. One is a one-liner. It happens in paper 1 and paper 2. So paper 1, you will have a one-liner coming. Paper 2, you will have a clinical syndrome. Don't think कि एक बार पूछा जा चुका है, so that cannot be the answer again. Many times you get repeat questions as well, right? So question number 11, the answer is B, that is tuberous sclerosis. आप गलत नहीं होगा, right? तो अगर आपसे examiner पूछे neurocutaneous syndrome, remember the keywords if you are asked about neurocutaneous syndromes. Remember the keywords. If examiner says brain tumors, SEGA, seizures, especially West syndrome, plus hypopigmented skin lesions, you should suspect tuberous sclerosis in the patient. Tuberous sclerosis. If the examiner says optic nerve glioma, hyperpigmented skin lesions, not hypo, hyperpigmented. What kind of hyperpigmented? Brown colored, coffee colored skin lesions called as 𝗵𝗄𝗃𝗏𝗃 macules. Sometimes they will not say 𝗵𝗄𝗃𝗃𝗏𝗃 macule. They will simply say hyperpigmented coffee colored skin lesion. And there are multiple neurofibromas or skin benign tumors arising from nerve sheath. Sometimes examiner will not use the word neurofibroma. So in such patients, your diagnosis will be neurofibromatosis 1. So watch out for keywords and you will always get. Remember, TSC1, TSC as well as NF1, both of them are showing autosomal dominant inheritance. So both of them tend to show autosomal dominant inheritance. And because we are talking about NF1, there is a diagnostic criteria which has been given. So the diagnostic criteria says any 2 out of 7 criteria, if they are present, it is diagnostic of NF1. So you can remember these criteria. This is something I have discussed in the detailed classes as well. It is there in your all the notes as well. So I'm just adding it here, this table, so that you can quickly go through it when you are doing the revision, right? Let us go to question number 12. 7-year-old girl is easily distracted in class and exhibits poor scholastic performance. Seizures are precipitated by hyperventilation. What is the likely diagnosis? What is the likely diagnosis? So there is seizure happening, which is causing difficulty in focus. She's getting distracted. There is a fall in grades and seizure precipitated by hyperventilation. What is the likely diagnosis? Patient is suffering from absent seizure. Remember, if the examiner says age less than 2 years, salam spell, or jerks involving head and neck in the body. Along with that, EEG showing hypsarrhythmia. And there will be low IQ or developmental delay. In such patients, the diagnosis will be West syndrome. West syndrome. Drug of choice, ACTH followed by vigabatrin, except if it is tuberous sclerosis that we have discussed, vigabatrin will be the preferred drug. If the examiner says age 3 to 10 years, female more common than male, and there is a brief vacant staring look, fall in school grades, so school performance is falling, easily distracted, and precipitated by hyperventilation, rapid and deep respiration like Kussmaul's breathing, rate and depth both are increased. The likely diagnosis is going to be absent seizure, also called as petit mal epilepsy. The other name for this is petit mal epilepsy, right? And in such patients, the first line drugs are valproate as well as ethosuximide. Most effective is ethosuximide, but most commonly used is valproate in patient, right? And third, if the examiner says age 10 to 18 years, female more common than male, and she's having myoclonic jerks in morning hours, there is a dropping of objects from the hands, and it is precipitated by sleep deprivation or stress, but there is normal IQ. I personally know a few doctors, interns, who are having this phenomena, but they have absolutely normal intellect. It is likely to be juvenile myoclonic epilepsy. JME, also known as Jan syndrome. And in such patients, the drug of choice will always be valproate. Yes, absolutely right. Juvenile myoclonic epilepsy, they have a strong positive family history. There is a strong positive family history. The most common gene associated with juvenile myoclonic epilepsy is a gene known as GABRA1 gene. ये AIMS का MCQ है, you can remember it as a one-liner. So GABRA1 gene. So these are the 3 important pediatric epilepsies which are asked in the exam. Absence seizure का याद करने का तरीका I have already discussed. There is a Hindi song, I made a reel also on that some time back. Before the world gets to you, the work gets to you, and you lose your creativity. This will happen with you people also, but I keep on rebounding. So, कैसे याद करना है absence seizure? There is a song in मोहब्बतें, चलते चलते यूं ही रुक जाता हूं मैं. There is a paucity of motor movement. बैठे बैठे कहीं खो जाता हूं मैं. Brief vacant staring look. कहते कहते ही चुप हो जाता हूं मैं. The person stops speaking mid-sentence and starts speaking from where he had left after the episode is over. क्या यही प्यार है? No, this is not love. This is absence seizure. Right? So when you listen to the song of 𝗏𝗏𝗧𝗏, you can revise that as well. If you don't like songs or if you're not well versed in Hindi, it's okay. You can still remember these keywords and reach the correct answer. The screen will be available to you, Nidhi. So I'm just going a bit fast because there was interruption for 7-8 minutes because of the some issues. And these topics are actually very easy. So my focus is on revision and trying to cover the maximum important topics. Question number 13. Dose of fractionated IPV in the patient. Dose of fractionated IPV in the patient. What is your answer? IPV is, there are two types of polio vaccines, oral and injectable. In National Immunization Schedule in India, we don't use the conventional IPV, we use the fractionated IPV. It is a smaller dose. So what is the dose of that? What is the dose of that? The answer is not 0.5 ml. The answer is 0.1 ml. Remember, polio vaccines are two types, OPV and IPV. OPV, the currently used OPV vaccine in the country is bivalent vaccine, provide protection against type 1 and type 3. The type 2 has been removed. So only bivalent OPV is used. IPV is of two types. We have the normal IPV and we have the fractionated IPV. The normal IPV is given via intramuscular route, sometimes by subcutaneous route. Whereas fractionated IPV is given intradermally. Sometimes it can be given intramuscular as well, some variants. But we give generally intradermally in the patient. Intradermal is the route. And what is the dose? The dose of the normal one is 0.5 ml. Whereas the dose of fractionated IPV is 0.1 ml. Yes, Salk vaccine. Salk vaccine word we do not use it. So type 1 is P1 and type 3 is P3. These are the older terms. These days we don't use the word P. We simply write type 1 and type 3, right? Dose is 0.5 ml, dose is 0.1 ml. And this is used in IAP program as well as Western countries, as well as in private practice, private hospitals. तो मैं अपने हॉस्पिटल में जो यूज करता हूँ वो ये वाला होता है. आई एम अ प्राइवेट प्रैक्टिशनर. बट इन द नेशनल इम्यूनाइजेशन शेड्यूल वी यूज फ्रैक्शनेटेड आईपीवी. This is the fractionated IPV which is used. And if you are using, what is the regimen that we use? These are given. The normal IPV vaccine is given at 6, 10, and 14 weeks. Whereas fractionated IPV is given at 6 weeks and then at 14 weeks. Right? 6 weeks as well as 14 weeks it is given. And then the third dose can be added. Third dose has been introduced at 9 to 12 months since 2023. Because it has been added, so it is a potential MCQ point. So it is a potential MCQ point. तो हम पढ़ते हैं पोलियो के बारे में, but this is something that we tend to miss out on. So what I have done is I have summarized them in a way that it is covering this MCQ, it is covering this potential MCQ, and this is covering this 𝗏PG MCQ as well. So remember it like this, it will be easy for you. Obviously, vaccines you have discussed in PSM class also, and some scenarios I have discussed in my face-to-face class as well. Some one-liners related to immunology, you can always read in addition. In case you people want, I will add, I had recently taken another lecture somewhere, so where I had discussed 15-20 one-liners related to vaccines, immunology. So what I will do is, because we have limited time and it is a discussion class, it is a MCQ discussion class, so I will add that into this file, right? So don't worry, you will not miss out on that. But these are just simply one-liners like rotavirus is contraindicated in intersusception. A live vaccine should not be given in which scenario? What should be the gap between two doses of the same vaccine, and so on? This is some one-liners I have collected that I will add in this file, right? Let us move without. It will be there. It will be there. The link for the PDF will be put up. It is already there in the YouTube session. After YouTube, the PDF will be given. Let's move further. Question number 14. 5-year-old male child suffering from nephrotic syndrome is responding well to steroid therapy. what will be the most likely finding on light microscopy application? What is the answer? Read carefully and give me the answer. Read carefully and give me the answer. There are two types of nephrotic syndrome. There are two types of nephrotic syndrome. The answer to the question is not D. The answer is, my dear friends, A. वो light microscopy पूछ रहा है. They are not asking electron microscopy. And this is a mistake a lot of your seniors have made. This is an actual FMGE MCQ. It is an actual FMGE MCQ asked 1.5 years back. It is an actual FMGE MCQ. Like, obviously not the exact same one, similar to actual FMGE MCQ, right? And this was the mistake many of your seniors made. So nephrotic syndrome in children is of two types. If the question says age 2 to 6 years, साक्षी यहां गलती कर सकते हैं, यहां गलती करना सही है. Don't make it in actually, right? So age 2 to 6 years, no hematuria, no hypertension, male more common than females, and good response to steroids. The patient is likely to have a disease known as idiopathic primary nephrotic syndrome. And in these patients, when you do histopathology, the most common pattern of idiopathic nephrotic syndrome is minimal change disease, right? Minimal change disease, MCD. It is called as minimal change because when you do light microscopy, normal change, normal glomeruli are seen, no change is seen. Bracket I'm writing, no change. Whereas when you do electron microscopy, you will find effacement of food process of porocytes. I was supposed to finish the class at 7:55 according to what I have been said, but because अच्छा discussion चल रहा है, subsequent questions also I want to go through them. A few flow charts I want to make. तो ऐसा करते हैं, इसको थोड़ा सा 20-25 minutes और extend करते हैं. I hope you're all okay with it, right? So I'm just dropping a message that please extend the session. On the other hand, if the examiner says age less than 1 year or more than 10 years, there is hematuria present in nephrotic, gross or microscopic, hypertension present. किसको इग्नोर कर दिया यार मैंने? किसी को इग्नोर नहीं किया भाई. Salk vaccine also name polio vaccine. Yes, मैंने already उसको respond कर चुका हूँ. I don't miss out on anything. Student नहीं हूँ मैं जो keyword को छोड़ दूंगा, right? So age less than 1 year, more than 10 year, hematuria, hypertension, and male equal to female, and poor response to steroids. Poor response to steroids. The patient is likely to have secondary nephrotic syndrome, and when you do microscopy, you will find significant glomerular lesion in the patient. Significant glomerular lesion will be found. Which significant lesion will be found? Remember that if it is a child, it will be FSGS. If it is a HIV patient, it will be FSGS. If it is a age more than 60 years or malignancy is present in the patient, malignancy associated nephrotic syndrome, it is likely to be membranous GM. MCQ, MCQ, MCQ. Keyword, watch for it. Very, very important. Right? Crescent नहीं होंगे. Crescentic glomerulonephritis is not nephrotic syndrome. Crescentic glomerulonephritis is RPGN, rapidly progressive. It is a cause of AKI. It tends to produce a nephritic picture rather than a nephrotic syndrome. Remember that. So crescentic GN is not typically included in nephrotic syndrome. Don't mix up the things, right? So watch out for these keywords. There was a medicine MCQ also. I'm not teaching medicine, but medicine MCQ also. There is a 70-year-old lady who had malignancy, weight loss, others, and she developed nephrotic syndrome where microscopic hematuria was present. What is the likely histopathological diagnosis you will suspect? The answer was membranous glomerulonephritis. 3 years back, medicine MCQ, you can find it in your past papers as well, right? So this is regarding the approach to the question and keywords to not to miss out on. Yes, steroid-resistant nephrotic syndrome, you use calcineurin inhibitor. This is something that we have discussed already in the regular classes. Mechanism by which phototherapy produces maximum effect in neonatal jaundice. What is the answer? Give me the answer here. Mechanism by which phototherapy acts. A, B, C, or D. What is your answer? When you use blue-green light in a wavelength of 460 to 490 nanometers, it gets freely filtered across the skin, reaches the circulating blood, and starts converting the circulating unconjugated bilirubin directly into polar compounds. Example, lumirubin. And this polar lumirubin is excreted from the body. This is how phototherapy acts. And this conversion, the most important mechanism is structural isomerization, where lumirubin is formed. It is structural isomerization. It's a one-liner question and it is a repeat question. काफी सारे लोगों ने गलत किया है. Repeat PYQs पे focus करो इस वक्त. Right? Close to the exam, focus on the PYQs. Most important is structural isomerization. It is irreversible. Others are reversible or not significant enough. And so structural isomerization is the answer here. Yes, it is irreversible. जो irreversible होगा वही काम करेगा. Otherwise, when blood will circulate, if it was reversible, whatever had been converted into polar compound will get reconverted back before it gets excreted, right? So question number 15, the answer is D. Don't get it wrong. Some of you have got it wrong. Question number 16, what is the likely diagnosis? Easy hai. Similar question, past MCQ it has been asked. Look at the photograph and give me the answer. Yes, bronze baby syndrome is a known complication of phototherapy. So what is the likely diagnosis in this girl child? Having short stature and features as shown. So can you see the webbed neck? She's having webbed neck. Webbed neck is present. Can you see this low posterior hairline? Also look at this and this. Short fourth. Metacarpal hand pe hoga and metatarsals. Metatarsal will be on the feet. Along with that, she's having short stature. So likely diagnosis in the patient. Yes, it is likely to be Turner syndrome. 45XO will be the genotype. 45XO. So there are a lot of key points about Turner-Klinefelter Down syndrome, very frequently asked in the exam. So don't get them wrong. Yes, if it is a male patient having pulmonary stenosis instead of coarctation of aorta or bicuspid aortic valve and having anti-mongoloid slant of eyes, the likely diagnosis is going to be Noonan syndrome. It is going to be Noonan syndrome. And Noonan syndrome is having PTPN11 gene mutations. It is not due to a aneuploid. It is not due to abnormal number of the chromosomes. IQ is normal in Turner. It is generally low in Noonan syndrome. Let us move further. Let us move to the remaining questions are easy. We are doing a quick revision of these. Child presented with palpable rash on the limbs, hematuria, joint pain, and history of respiratory infection 1 week ago. What is the probable diagnosis? Very similar to actual MCQ asked in 2021 FMGE exam. Yes, Jesh, Sickle syndrome is one of the causes of short stature. Short stature has a huge list of causes. Yes, Saket, RAS MAP kinase pathway, absolutely right. Ronak, white filtrum is also present. I'm just telling the keywords here. It's a revision thing. So we are only focusing on key points. So what is the probable diagnosis? Absolutely right. Henoch-Schonlein purpura. So remember, whenever there is a patient, there is a child, can occur in adults also, there is an initial infection followed by 1 to 3 weeks later, there is onset of rash, joint involvement, GIT involvement, and renal involvement. This is considered the tetrad of HSP in the patient. What kind of rash will be seen? It will be a palpable petechiae and purpurae present on buttocks and lower lips. It can also be present on the pressure points. And there will be no thrombocytopenia because it is due to vasculitis. And secondly, there will be arthralgia or arthritis, either pain in the joint or inflammation in the joint. Third, it will be GIT involvement in the form of colicky, abdominal pain. Rarely intussusception can occur. And fourth, there will be HSP nephritis. It will produce the typical nephritic syndrome in the patient. So acute nephritic syndrome will be produced. So glomerulonephritis producing proteinuria, hematuria, hypertension, oliguria will be present in the patient. So these are the 4 features which are present. And HSP is also known as IgA vasculitis. Because IgA deposition is seen, so biopsy can be useful in doubtful cases. Treatment in most of these patients is conservative therapy. If there is severe GIT involvement, you will be using oral prednisolone. So steroids are indicated in severe GIT involvement. Again, those who have attended my class, you would know I have been teaching this. I have taught this multiple times. INI-CT last month. This was another question. Which of the following is indication to give steroids in a patient of HSP? This was the question, right? You know the answer, severe GIT involvement. See, the point I'm trying to make is that wahi cheezein hain, same topics and similar things are asked again and again. So you need to have that accuracy and you need to imprint whatever things that you have read in your notes already in your mind and have a look at them to get that confidence going close to the exam. So close to the exam, whatever topic you feel underconfident, just try to skip through and have a look at the notes. These things will come back to you in the exam because in exam, option will be written there. All you need to do is correlate with what was written in the copy that you had, the notes that you had made. And if you have read them sincerely, you will get the answer in the paper, right? So go do a proper revision. Don't try to read cover to cover, running short on time, focus on topics which are PYQs rather than randomly reading from first page to last page. Yes, ESRD can also be seen. Question number 18. Now, this is a overlap kind of topic, and it is a topic that we don't normally discuss that much in details, but I will be highlighting the keywords if you get a similar question in the exam. So old MCQ one-liner has been asked in FMGE. So 3-month-old HIV positive child following upper respiratory tract infection, URTI, upper respiratory tract infection, viral throat developed sudden onset of breathlessness with intermittent expiratory wheezing. The chest X-ray shows hyperinflation. Oxygen saturation was greater than 90%. What is the treatment of choice? So you need to make the diagnosis. How to approach a question like this? Any child aged less than 2 years, presenting with fever, URI, upper respiratory infection like symptoms, along with bilateral expiratory wheezing. Wheezing will involve bronchi and bronchioles. Remember, it will not involve the upper airway. Asthma mein hota hai wheeze, bronchiolitis mein hota hai wheeze. And X-ray is either normal or shows hyperinflation. What should be suspected in the patient? You will suspect a condition known as acute bronchiolitis. Acute bronchiolitis. Some people will say कि सर ये pneumonia क्यों नहीं है? Pneumonia में there will be fast breathing and chest indrawing, and they are not mentioned here, right? So acute bronchiolitis, most common cause is respiratory syncytial virus. Treatment in the patient is conservative, supportive. With supportive therapy, oxygen alone, patient comes out in a few days. However, if it is a HIV positive patient, that is immunosuppressed, or having congenital heart disease like VSD, or having chronic lung disease, in such patients, you will be using ribavirin. Because this patient is a patient of likely bronchiolitis with HIV infection, so ribavirin will be the answer. So answer to this question is B, ribavirin. And is there a prophylactic agent available for RSV? Yes, there is a prophylactic agent known as 𝗵𝗿𝗺𝗺, monoclonal antibody, which is available to prevent recurrent infections in children. So prophylactic agent. So अगर पूछे, तीन तरह के MCQs can be asked. If they say what is the therapy of choice in bronchiolitis, conservative. If they say which drug is to be used under specific scenarios where life-threatening infection can happen, ribavirin. Which is the preventive drug, not therapeutic, preventive drug, 𝗵𝗿𝗺𝗺, which is a monoclonal antibody, right? So this is a brief summary of the topic also, the keywords to watch out for, and the question as well. So ये जो additional things that you are finding, make sure that you write somewhere and have a look at them at least once. And the same video which I am discussing, 2x or 1.5x or 1.75x speed, just go through them fast. Question number 19. 3-year-old boy has complaints of chronic cough, foul-smelling, bulky and sticky stools, poor weight gain. Salty taste is felt by the parents on kissing. Sibling death with similar complaints. CFTR gene mutation was detected. Which iron abnormality should be checked for confirmation of the diagnosis? Neat PG question. But you know the answer. The patient is suffering from cystic fibrosis. Cystic fibrosis occurs due to CFTR gene mutation. And which is the channel which is deficient? Chloride channel is deficient. Yes, Mohammed, answer is right. Cystic fibrosis and chloride channel is most common. Most common type of gene mutation is delta F508, now known as deletion 508 phenylalanine residue. So deletion 508 in phenylalanine residue. This is the new name of delta F508 mutation. Second common mutation is G551T. So gene mutation also important for your exams. So question number 19. It's more of a one-liner kind of question. Chloride. Question number 20. Repeat question. Easy one. Child with noisy breathing was found to have stridor on examination. Stridor on examination. His laryngoscopic finding is as shown. What is the likely type of stridor in this child? This is a omega epiglottis. So omega epiglottis with noisy breathing, that is stridor. The patient is likely to be suffering from laryngomalacia. Laryngomalacia involves supraglottic larynx. And so which type of stridor will be present? Supraglottic larynx is always inspiratory stridor. ENT pediatric overlap. And this is a thing that has been discussed by myself also and Rajiv Dhawan sir also. Right? So question number 20A, inspiratory. जब ये question repeat होगा, अगर होगा, तो जब recall होगा, so I will also be putting it and ENT person will also be putting it. So many times recall sessions can be misleading. We tend to feel that a particular subject is giving you more questions and one particular is giving you less question. The question which we solve easily, we tend to forget it. The question which was controversial, we tend to remember. When you are giving the exam, if you are finishing within time limit, without losing your patience, and all the sessions are going fine, there is a 95% probability you will clear the exam. Unless you make stupid, silly mistakes, right? Thoda bahut silly mistake everyone will make. So what is important is that you keep your cool and finish within time limit for each session. Time management is going to be the key, and keep 5 minutes spare in each session so that you are reading the screen and suddenly the screen changes for the next session. That should not happen, right? So keep your cool in the exam. Question number 21. 3-year-old child. This is a question again, similar question, high likelihood for your exams. Pneumonia, diarrhea, neonatal resuscitation, milestone, severe acute malnutrition, HSP, pediatric epilepsies, and CNS infection. You always get questions from this. Running short on time, at least go through these topics. So read the question. Yes, option दूसरे होंगे. What is the diagnosis here? Pneumonia, no pneumonia, or severe pneumonia? There is no such thing as very severe pneumonia. And labeling will be same. No pneumonia is green, pneumonia is yellow, and severe pneumonia is pink. So what is the diagnosis? Patient is having respiratory rate. Any respiratory rate more than 40 in a 1 to 5-year-old child is tachypnea. So fast breathing is present, but no danger sign mentioned. No danger sign mentioned. So likely diagnosis in the patient. Likely diagnosis in the patient is going to be start oral antibiotics and review in 48 hours. Start an oral antibiotic and review in 48 hours. If they say that the patient is having severe acute malnutrition, now there can be a school of thought which can overthink here. कि सर 3 साल के बच्चे में 11 किलो क्या ये ठीक है? It is slightly on the lower side, but there is no other feature of severe acute malnutrition mentioned, and there is no weight for height below -3 standard deviation mentioned. No edema like Kwashiorkor like thing mentioned. So you will not assume the weight is on the lower side, but it is a fairly common scenario you can find in the Indian setting. If they don't mention the word malnutrition or a feature of malnutrition or some danger sign mentioned, you don't overthink of severe pneumonia. Simply think it as pneumonia. And in pneumonia, start oral antibiotic like amoxicillin and review in 48 hours. Details I have already discussed in the details class. So remember, fast breathing. Remember the key point, fast breathing or chest indrawing. Either of the two, that is considered to be pneumonia. Yellow label, yellow color. Oral amoxicillin should be given in the patient, given for 5 days. But call the patient, review the patient in 48 hours in all such patients. So review in 48 hours. Question number 22. Easy one-liner. Mother notices. Ronak Kumar, croup में subglottic होगा या supraglottic? Ronak, most of the croup, initially it is inspiratory because there is upper airway involvement. But as it comes down, remember that steeple sign. So mild croup generally has inspiratory, severe croup has biphasic stridor. Remember that. This is what is mentioned in the pediatric standard textbooks. So child's diapers turn black on oxidation, on exposure to air. It's a pigment disorder, inborn error of metabolism, 𝗏𝗏𝗃𝗏. ये गलत किया. So this is a crime, getting a question like this wrong. Don't make stupid mistakes. Don't overthink. It is 𝗏𝗏𝗃𝗏. So remember, fair-skinned child, mental retardation, seizures, and musty odor in urine will be phenylketonuria. But urine turning dark will always be 𝗏𝗏𝗃𝗏 in the patient. And then the inheritance, enzyme deficient treatment, that is something that you have already read in pediatrics also, in biochemistry also. Question number 23. Yes, PD and biochem. I don't know who you are. But if you make mistakes in questions like this, I will find you. I'll not kill you. I'll make you sit and read this again. Because if you make stupid mistakes like this, even if you pass FMG, you will have a great trouble in getting internship because your score will not be great. And you will have problems in NEET PG again later. I hope all of you know that if you get a good score, in many states, your merit list decides how fast you get internship. So getting a good score is equally important. The most important thing is crossing the line, but also cross the line with a good. It's like playing a World Cup match, not only winning, but winning with good run rate. That is what you need. So there is still time. I still say there is still time. So read the question and give me the answer. So the child has Finnish type of congenital nephrotic syndrome with NPHS1 gene mutation. Which of the following protein will be deficient producing in this lesion? The answer to this question is not podocin, it is nephrin. So what is congenital nephrotic syndrome? I'm doing a very quick review. Congenital nephrotic syndrome is said to be there when there is onset of nephrotic syndrome. When there is onset of nephrotic syndrome before 3 months of age. That is, in the first 2 months of life, patient develops, the child, the infant, it develops periorbital edema spreading to whole body, anasarca develops, hypoalbuminemia, and may or may not have other renal abnormalities. So onset of nephrotic syndrome before 3 months of age. Many types have been described, but there is two common varieties, relatively common varieties, which are shown. The 2 common varieties you need to know. First variety is known as type 1 congenital nephrotic syndrome, also called as Finnish type, because it was described in a family of Finland. And there is type 2, which is known as classic SRNS. SRNS stands for steroid resistant nephrotic syndrome. होते दोनों हैं, both of them are steroid resistant, but the nomenclature is that. Finnish type 1 occurs due to NPHS1 gene mutation. This occurs due to NPHS2 gene mutation. They will not ask the chromosome number. All you need to do is remember the nomenclature, subname, gene, and the protein deficient. This has deficient protein nephrin. This has a deficient protein known as podosin. Nephrin and podosin are slit membrane or basement membrane, slit membrane and basement membrane components, and their deficiency leads to proteinuria since birth. So that is congenital nephrotic syndrome. Treatment is unsatisfactory, and they are found to have a very high mortality. They are found to have a very high mortality. Can some drug produce some symptomatic improvement? ACE inhibitors like enalapril have been found to reduce the degree of proteinuria. They may have a role. Not given for hypertension, but given for their anti-proteinuric effect. Right? So this is a brief review of the topic congenital nephrotic syndrome. Question number 24. Which heart disease is most commonly associated with the following abnormality? Which heart disease is most commonly associated with the following abnormality? What is this? This is a patient who's having a hairy pinna. And hairy pinna is a morphological marker of which condition? Infant of diabetic mother. And what is the most common heart disease found in infant of diabetic mother? Ventricular septal defect, and that is the mass. Right? So hairy pinna, infant of diabetic mother, VST. Remember it like this. If they ask you what is the most common metabolic abnormalities found in infant of diabetic mother in decreasing order, I'm writing hypoglycemia. If blood glucose level is normal, what other test you will do? Check for calcium level, because hypocalcemia is common. If that is also normal, check for hypomagnesemia. So these in decreasing order, these are the three important metabolic abnormalities found in infants of diabetic mother. This is one condition where prevention is better than cure. Prevention is better than cure. They will have other problems like neonatal jaundice, increased risk of birth injury, shoulder dystocia, caudal regression syndrome, etc. So I'm not going into the details. It's a detailed topic that you have already read. My focus is on doing a revision. This revision is highlighting the key points and also making you think how much you remember. And after this session is over, I hope you will open your notebooks again and write down the points plus correlate and give a quick reading. And these topics, you will always remember them. So which heart disease? Next is an easy one. Which heart disease is most commonly associated with rubella infection? This is an easy one. Which heart disease is most commonly associated with rubella infection? Obviously, congenital rubella. Postnatal to heart ban chuka. So which heart disease is most commonly associated? It's an easy one. Don't get it wrong. PDA. So congenital rubella syndrome. It is characterized by a triad of three things: deafness, that is sensory neural hearing loss; cataract, that is eye involvement; and patent ductus arteriosus. If that is not in the option, the second heart disease you can mark pulmonary artery stenosis. That will be the second best answer in the patient. Good evening, Ishaq Riaz. आपने भी join किया है. We are almost close to finishing of the session. There is a conference and a CME going on in Chandigarh right now of pediatrics. I will not maybe listen to the academic part, but I hope to be there for the dinner. Dinner नहीं छोड़ना चाहिए free का. You people do your revision, don't miss your meals, and I will attend my symposium, but not before we finish up with the last 5 MCQs. Are Ishaq, you have passed. Great, great. Congratulations. Congratulations. So you can always listen to the discussion. Who knows, this may be asked in your NEET PG or INICET. Yes, Varun Sani, Dhoni ki taraf baad mein aana hai, but you have to make an impact, even if he has made an impact already. He has cracked the exam already. अंकित सिंह, टॉवल शैम्पू भी भाई, टॉवल नहीं चुराया, शैम्पू चुराया कभी कभी. शैम्पू भी उठाया है, चुराया नहीं है आजकल, बट टॉवल नहीं लिया है. आगे चलते हैं. Yes, Andhra Behra Bacha, labutal, absolutely right. Which of the following is the most common cause of abdominal mass in neonates? There is a thunderstorm in Chandigarh right now. Anybody from this part? No. And the light is gone, so there is only a fan which is working. No AC working right now. So, but work has to continue. So most common cause of abdominal mass in neonates, one-liner, past MCQ. What is the answer? What is the answer? गलत, सबके सब गलत, सब गलत कर. Multicystic dysplastic kidneys. अब हम लिखेंगे one-liners. लिखो, write down. If the examiner says most common abdominal mass in neonates, it is MCDK, multicystic dysplastic kidney. If the examiner says most common abdominal tumor, for malignancy in the newborns, then the answer will be neuroblastoma. Overall, MCDK is more common than neuroblastoma. A benign thing is always more common than a malignant thing. Remember that. So most common abdominal tumor in neonates, neuroblastoma. If they say most common abdominal tumor in age up to 1 year, the answer will be again neuroblastoma. Most common abdominal tumor in age 2 to 5 years, it will be Wilms tumor. Wilms tumor. And if they say most common abdominal tumor associated with paraneoplastic syndromes, I hope you know what are paraneoplastic syndromes. That will be again neuroblastoma. इसमें syndromes होते हैं, Horner syndrome, Hutchinson syndrome. When you are discussing, the dad will start calling you. But I'll ignore. Let us continue. Let us continue. Question number 26 is done. Question number 27, easy one. Read the question and give me the answer. Read the question and give me the answer. Hey, all of you people, focus on the class. Don't get distracted. Don't get distracted. Focus on the class. Stay focused. Exam is coming. So, cleft lip and cleft palate, polydactyly, microcephaly, brain showing holoprosencephaly, where the two cerebral hemispheres do not separate. Ectodermal scallop defect. What is the likely diagnosis? Patau syndrome. And what is the genotype found in Patau syndrome? Trisomy 13. Don't get it wrong. If the examiner says rocker bottom feet, microcephaly, anterior abdominal wall defect, and overlapping digits, the answer will be Edwards syndrome. And Down syndrome is something that you already know. Turner syndrome we have seen. Klinefelter, tall male with infertility, aggressive behavior, but gynecomastia present and not able to bear children because of infertility. That is Klinefelter syndrome. So these 5 syndromes are very frequently asked. Don't get them wrong in the exam. When you get this file, I will be putting a sprinkling seasoning on top of it. What is seasoning? You get a pizza, but then you sprinkle those oregano on top of it. The oregano will be some tables and some one-liners, which I've already taught. But I will fill up these things for you in case someone, I understand many of you have not maybe attended my regular class. So you might be feeling ki sir thoda aur bata do. So I will make sure that everyone gets something in addition to whatever we are discussing here, right? So I'll put that in the file that you get. Question number 28. What is the preferred test for HIV diagnosis in an infant aged 9 months? Read carefully and give me the answer. Latest guidelines. Latest guidelines. Answer to this question is C, HIV, TNA, PCR. What are the latest HIV guidelines? First of all, any baby born to HIV positive pregnant female, the baby is labeled as HIV exposed infant. In this HIV exposed infant, start exclusive breastfeeding. Second thing, start antiretroviral prophylaxis. If it is a low risk infant, the baby will be started on oral nevirapine, which will be given daily for 6 weeks. If it is a high-risk infant, typical example, if the mother is not taking ART, mother is HIV positive but not taking therapy, drugs नहीं ले रही है, so you will give combination therapy, nevirapine plus zidovudine will be needed in the patient. Nevirapine plus zidovudine will be needed. And what will be the duration? If breastfed, the duration will be 12 weeks. If replacement milk fed, replacement milk will be formula milk or non-mother's own milk, then duration will be 6 weeks in the patient. Yes, Uzma, topics are the same. In fact, I showed 2 questions to the students, which have been asked in INI-CET also in the previous exam, right? So you can always listen to it. And you can listen to the entire session also later on. And third thing is HIV diagnosis. Remember, HIV diagnosis, the method of HIV diagnosis is known as DBS method. DBS stands for dried blood spot. You don't take the whole blood, you take some capillary blood on a sample paper, on a blotting paper, and let it dry. That is dried blood spot. What is the test that is done? That is PCR for HIV. TNA. What is TNA? Total nucleic acid. This test is available in India, and according to WHO, TNA should be preferred, both DNA and RNA. This will include DNA as well as RNA, which should be preferred. If not available, you are not given in the MCQ option, then your answer will be PCR, HIV, DNA. But that will be the second best answer. So look for HIV total nucleic acid, that is DNA plus RNA both. If such an option is not there, then your best answer will be PCR, HIV, DNA. So answer will depend upon the options which have been given to you, right? And it will be done at 6 weeks. It will be done at 6 weeks. The first test should be done at 6 weeks. And if breastfed, you will do every 6 monthly till 18 months of age. And also remember, as a last one-liner, if age of the patient is equal to or more than 18 months, do HIV ELISA for HIV screening. No need to do PCR in these patients. You can do ELISA. So if they give a 1-year-old child, the answer will be PCR. If they put a 2-year-old child, the answer will be HIV ELISA. Antibody testing can be done. HIV ELISA antibody cannot be done before 18 months because maternal antibodies may cause a abnormal persistence sometimes, and they can interfere with correct interpretation and diagnosis. And question number 29, as per NRP, what is the target preductal SpO2 in neonates at 3 minutes of life? This is an indirect question based upon NRP, Neonatal Resuscitation Program. What may happen is, आपने पूरा NRP पढ़ लिया, but you don't read this table. And this table is given in the NRP guidelines. And so that is why I have put this question. So what is the target preductal SpO2 at 3 minutes of life? You don't target more than 90% immediately. More than 90% is targeted after a few minutes of life. So there is a table you are supposed to remember. And yes, the answer to this question is absolutely right. B, 70 to 75%. Rajat has answered it correctly. This is the table you are supposed to remember. Have a look at this table. At 1 minute, the SpO2, remember right hand mein lagaya tha, it should be 60 to 65%. 2 minutes pe 65 to 70. 3 minutes, 70 to 75. 4 minutes, 75 to 80. 5 minutes, 80 to 85. And only at 10 minutes, it crosses the 90% value in most children. So 85 to 95% will be considered as normal. And what is the initial oxygen concentration to start when you start PPV? If it is 35 weeks and above, room air should be good enough. Room air, that is 21% oxygen. Less than 25 weeks, you will be using 21 to 30% oxygen. And 100% oxygen is given when intubation along with chest compression is given in the patient. This is the time 100% oxygen is given. So please, I'm putting a big star over here. Please add it to the notes in case you have missed out on this particular table. Very, very important. Who knows? Only a single question is asked from NRP and you have read everything in NRP except this table. Don't let the situation happen. If questions are coming beyond your notes, it's okay. The subject, the paper is tougher. If one subject is tough, some other subject will be easy. Right? So question number 29, add this table to your notes. It's a one-liner question. If you remember the table, it's an easy one. Last question of the day. Gas bubbles are present in portal vein. They first appear in what stage of necrotizing enterocolitis? Which will be the answer? Gas bubbles in portal vein first appear at what stage? Gas bubbles first appear in what stage? Gas bubbles first appear at what stage? Give me the answer. Necrotizing enterocolitis, modified Bell staging is followed. You all know it. Yes, stage 2B is the answer. 2B में 2A में radiological hallmark appears. 2B में portal vein gas appears. So pneumatosis intestinalis first appears in stage 2A. 2B में you will have portal vein gas. 3A में definite ascites and a rupture, pneumoperitoneum, gas under the diaphragm, football sign, air under the diaphragm will be seen in 3B. And so the answer to this question is B. And this is the table where modified Bell staging in a simplified manner I have already added. This is something that I discuss in my class also. Remember that stage 1A to 3A, the treatment is conservative. Conservative therapy is given. Whereas 3B, surgery needs to be done. Perforation has happened, so laparotomy needs to be done in the patient. So this is what you need to know. I hope you have been refreshed a bit. Some of the additional things you have already done. Some of the additional points you have already discussed. I have added some information, but I have not tried to create any shock value for you. 2 or 3 questions were there which were a bit of mind-boggling, but such questions will be there in actual exam as well. So I hope you benefit from it. It was a Super 30 session. Went for more than the time we had planned, but 2 hours, 30 topics we have tried to discuss. So I hope you benefit from it. All the very best. Blessings are with you. Best wishes are with you. You all know well. But in case you are still feeling you are underconfident, there is still time before the exam. Next 10 days, 12 days are going to be extremely important. Give your best shot. Don't skip meals and focus on the more asked things. Any topic repeated more than 2 times. If you have not read and it is coming in PYQ, read it from the books. Right? Don't try to overdo here. And additional things, if you have found, you can add to your notes. This PDF, after adding a few points, as I said, I have to rush now. Obviously, I can't go in wearing this marble thing in a professional place. So I have to go to Marriott, JW Marriott in Chandigarh. I have to attend a dinner over there. So I'll just change, attend the dinner, come back. Before I sleep, I will add the points I told you. And this file by midnight, I will share with the team. They will upload. The link for PDF is there in the description of this video. It is there in the description of this video. Thank you. Thank you so much. All the very best. And stay in touch. God bless everyone. Once you get selected, drop me a message. Ho gaya. Job done. I'll be very happy. End of the day, yes, every subject matters. So even if pediatrics is well done, other subjects also you should be focusing. As for medicine, this is not the place to talk about it, but yes, a few revision things of I will be putting this weekend itself. So Saturday, Sunday, don't miss out. You can add some additional things if you want, right? So thank you so much. Bye. Good night. Good night, everyone.